Thanks very much for having me, everyone. It's a real pleasure to be here. And as was said, I would also like to acknowledge the traditional owners of the land, wherever you are, and certainly where I am, and to pay my respects to elders past, present, and future. My name is Suzie Hudson, and I am indeed the Clinical Director from NADA. So we're the peak body in New South Wales, and you indeed have your own peak at QNADA, and so hi to all my colleagues there. I also have another very special colleague with me today, Florence, and she's representing NCRED. So that's the new leadership centre that's really focused on new and emerging drugs of concern. And I suppose really want to thank Insight for having us here today. For those of you joining us online, make sure that you send through your questions. I'd really like to hear from you, and anything that you would like some support on afterwards, I'm sure we can get some other bits and pieces out to you. So what have you heard about ICE? I suppose when I came to work in this field, I've been working in drug and alcohol now for about 20 years, and certainly in the last 10 have been particularly focused on crystalline methamphetamine. And really, I suppose we've had quite a journey in terms of the hysteria around this drug in particular. And what we also know is that not a lot of it is based on fact. And so today, what I really am hoping that you'll take away is a true understanding of some of the complexities associated with this substance, but also too about the important role all of us have in really addressing some of the stigma and discrimination around this drug. So today I'm really hoping to provide you some information to really talk briefly about some current patterns of methamphetamine use. And I know there's been a previous Insight presentation that's provided you some really great evidence, the epidemiological evidence across the country around methamphetamine use. But I suppose I'm hoping to drill down in how we might assist and support people who use methamphetamine, and for those who perhaps experience issues related to their methamphetamine use. I also really want to talk a little bit about some best practice approaches and what we know or feel relatively confident can work for supporting people, and to really think about what's next in terms of what research is going on out there in the field. What's really interesting about amphetamine type substances or stimulants is really that we can often be given the impression that methamphetamine in particular is all brand new, a bit scary and has sort of landed on us. And in fact, that's not the case. It's actually been around for a very long time and used in lots of different ways. And it will become as no surprise to you as we explore how the drug works, why it's been used particularly in war, and really, I suppose, why it's really a bit of a drug of our time in terms of its stimulant effects. And a bit of credit to the Australian Drug Foundation. This slide is in particular from a range of resources developed by Annie Bleeker as part of a project that she was doing with, and I was involved in with the ADF. And I would really encourage you to check out some of those resources because it does give some good tips around holding community forums around methamphetamine. So here's some of the data, and I suppose the key thing to note here is that alcohol is still the major drug of use across Australia. And however, it is fair to say that there's been increasing concern around methamphetamine, and so I wouldn't want to detract from that, but I think it's important for us to understand that a lot of the media and a lot of the messaging we get is that it's everywhere, everybody's using it, and everybody's experiencing harms, and they're the things that we need to start to address, particularly if we're in the treatment sector, but I think also in terms of the broader community. What are the messages that the community is getting about this drug that perhaps actually gets in the way of people reaching out for support and assistance if they need it? Similarly, in terms of the facts, it's really about saying that what we know is that while we've sort of plateaued in terms of over the population use, what we do know is that those people who identify as using methamphetamine are perhaps using the crystalline form, they are using it more frequently. And one of the things that we saw, particularly from the treatment side of things, is a real spike in presentations to hospital, really indicating that the impact of the drug really affecting mental health in particular, and so and people waiting long periods of time to reach out for assistance, feeling perhaps that there weren't appropriate services available. Similarly, in terms of what we know, particularly say in New South Wales, is that it's sometimes, and I think similarly for Queensland and other areas across Australia, it's often in the rural and regional areas where there are greatest concerns. And partly that's because of the very, I suppose, physical nature of the drug, the impact on mental health, and therefore the quite visible nature of the drug. And we'll explore a little bit in a moment about why that might be. And certainly, I suppose, that we saw with that real push around advertising a true focus on violence and a lot of fear. And so what that really has done is escalated that area of concern for communities that they may be in danger of people using this substance. And so that's where we've seen a lot of the footage that really shows people I suppose, acting out in ways that perhaps are very frightening to the community. And I suppose what I want to try to unpack today is why that might be. Why do we see some of those behaviours, and what is it that we might be doing differently in terms of supporting people? So what is methamphetamine? And I'm sure a lot of you already know this, but I suppose it's important for us to really understand how it works. So it's a central nervous stimulant. It's really acting on what are naturally occurring chemicals already present in the brain, and that is serotonin, dopamine, and noradrenaline. Now we need these chemicals in our brain to do lots of different things, regulate our moods, absolutely regulate patterns in terms of sleep, and really that whole feel-good, they're feel-good drugs or chemicals in our brain. And noradrenaline really helps with that responding to danger. And so in that way, this drug is really working on the release of all of those naturally occurring chemicals in our brains, but in a very accelerated way. And so it's not surprising that some of the key experiences for people is that increase in arousal, alertness, and that feeling of euphoria. We also know that it's a synthetic substance, so that it's being produced by people in lots of various ways, but we also are aware that a lot of those precursor chemicals, if you like, were quite freely available to people, and certainly over the time a lot of those have now been either restricted or banned. However, that hasn't really impacted the amount that's being produced. And so it speaks to I suppose, the necessity to think more broadly about not just that demand reduction, but also where people are accessing the substance, but more importantly to think about what's going on socially in terms of supporting and helping people. So it comes in those three different types, in three different forms. We talk a lot about the powder. What we know is that that's simply that crystalline form, which is the main form that people are using, that may indeed lead to some harms. It's a very pure form, the crystalline form, and it's that form that's being broken down into the powder form, and so we would say that that is less potent than the crystalline form. The base form is often a byproduct of the producing or manufacturing process. It's not necessarily desired, but certainly some people would report using base, but it's a lot harder, obviously, to use. We know with the crystalline form that it's frequently smoked or injected. And that's quite key for us to understand, because it also tells us something about the types of conversations we would want to be having with people who indicate they are using methamphetamine, because we know that both smoking the substance and injecting really are a very effective route of administration of any substance, and so that there is a very strong effect on the person, and that can have implications for dependence and certainly people really craving the drug. It also has us really thinking about key areas of harm reduction and the need to really speak with our clients comfortably and confidently about the ways in which they can reduce the harms in relation to the use of this substance. So certainly we would also be wanting to explore whether indeed not only are they smoking, perhaps predominantly, usually, but perhaps when they get together with other people, they wouldn't necessarily identify as being an injecting substance use, someone who injects drugs, but certainly they may well, on occasion, be injected by others or inject themselves. And so it's useful for us to really explore some of that so that we can absolutely provide that harm reduction information. So some of the effects that you would expect to see from any central nervous system stimulant is really that euphoria. That's what people are seeking. But I think it's some of the other types of impacts that are really important to explore, and that is that idea of alertness, of energy, of confidence. And we'll explore in a moment why that is, why it works in that way. But it does help us to start to unpack and understand the drivers behind why someone might use this substance. I think that's the part that we often don't talk about, and certainly we don't explore in the community, is why would someone want to be using this substance? I mean, you often hear that in lay conversation around the place because of those images that we've been presented with. And I think what that does is it stifles conversation about why someone might choose to use this substance and how it fits, I suppose, with a modern life. Obviously, after prolonged use of this substance, the difficulties really start to head into some of those mental health impacts. So, having a high amount of alertness over long periods of time with no sleep, and anyone who's studied or has a child and has been up for long periods of time knows that it will absolutely send you a little bit stir crazy. So we can start to appreciate these compounding impacts in terms of some of the long-term effects if people have been on using this drug for prolonged periods of time. And we also know with that heightened arousal, particularly of even the somatosensation, so that is on your skin, that risky or at least, adventurous sex practices can go on. And I think that's another key point that I'd like to really just explore with you today, is how do we also engage with people to talk about how or the links there for them in terms of sexual expression and sexual adventure and what we might talk with people about in that respect as well. So I wanted to just alert you to this video. This is one that you can find on YouTube and we'll provide to you. And a reason why I don't want to play it right now, but I do just want you to have some access to a couple of different ways of talking with both clients and community about how it works on the brain. One of the things that we don't always talk about, but something that certainly in my experience with working with people who use this drug have found really helpful and interesting, is how does the drug itself actually work on the brain, on the body. And as I was saying before, being a central nervous system stimulant, when methamphetamine enters the bloodstream, it's really serving to release what would be all those naturally occurring chemicals that would, in an ordinary day, be released very slowly and gently. If we're having a nice walk on the beach, or we're eating some nice food, or we've seen someone we like, or we're having good sex, that it would be released quite gently and then would be taken back up by the brain and the body to be used for later, for other, going forward in terms of that more consistent release of those naturally occurring chemicals. When methamphetamine is introduced to the bloodstream, it's releasing all of those powerful serotonin, dopamine, and the noradrenaline all at once. It's flooding the system. But the other thing that's happening is those receptors that are releasing those naturally occurring chemicals are also blocking the reuptake of those of dopamine and serotonin. And so what that the impact of that, of course, is, as you can appreciate, is not only is the brain now flooded with these chemicals that are making people feel that euphoria, that confidence, stimulating all of the senses. So all the senses are working overtime, visually, in their hearing and those somatosensations. Those naturally occurring chemicals are not able to be taken back up by the brain. So they're being blocked. And that then leads to that prolonged experience. So people may be talking about being up 8 to 24 hours. And usually the experience of using this substance is one in which people will they might then top up, as they may often do with other substances. And so you've got this very powerful experience, but then as over time, there's only so much of these naturally occurring chemicals available in our bodies. And so you can then start to have some ideas about that idea of a crash phase. So that person's been up for a very long period of time. They're now, those naturally occurring chemicals are now depleted. And so it gives us some tips and thoughts about the things that we might need to be aware of in terms of supporting someone, but also what you might see in terms of some of the behaviour. So in terms of that, what's going on in the brain side of thing, it then starts to help us understand some of the other aspects of some of the behaviour and some of the experiences that people may talk with us about, that it's impacting that frontal lobe. So, particularly if we're talking about the experience of that fight or flight or freeze that's happening in the limbic system. So that is that very primal experience of, you've got that flooding of the system. The brain is starting to think, right, okay, all the senses are working overtime. That part of the brain that's really controlling that fight, flight or freeze is switched right on. And what naturally will then occur is the brain trying to understand, why is my body in this flight, fight or freeze status. And so that's where we then start to see some of that paranoia experience kick in, because the brain is trying to make sense of what's going on. That then also helps us to understand a few things about what's attractive about the drug. So being really in that state of high arousal, really feeling quite powerful, if you like. So what we know with the fight or flight response is that blood is rushing to our major muscle groups, ready to run or to fight. And so that then tells us something about where that emotion dysregulation experience may kick in. Then that helps us also understand that, if someone's all those senses are aroused, we're in that fight or flight mode, we're feeling, either slightly paranoid, so some of that distress might be kicking in, or that sense of powerfulness taking that person into that experience, then adding something like police intervention or a hospital emergency department where there's lots of noise and light, you can start to appreciate why we may see some of the behaviours we see. And it tells us something about where the person is at and how a different kind of approach or different response may be more helpful. So I put this very old model in front of you. Some of you who are as old as me will know that Zinberg came up with this very rudimentary way of thinking about substance use. And I do think it's quite useful in the methamphetamine context. And that is just to think about, when you're speaking with clients, is really thinking about not just what the substance is in terms of their experiences, like what its effect on their bodies, bringing that into the picture, because that's sometimes what we don't necessarily speak about. And I do think it's really effective when talking with people about this drug in particular. So really talking about that physical experience of the substance, why we feel what we feel, why we see what we see, and why someone might experience some of the things they do. Then really thinking about that individual experience and association with the substance, because that's often the story that's not talked about too, and really trying to find out for people, what is it about methamphetamine that really works for them, what is attractive about it for them. And when I think about, certainly hearing a lot of the experience of clients and people I've worked alongside, it's a lot of that, it fits a lot with that modern world. You know, what are the things that are valued in a modern society is really about working harder, playing harder, experiencing everything. And this substance works really well for that. You can indeed do more, at least initially. That doesn't obviously, unfortunately, it's not prolonged, but certainly it starts to help us understand the role the substance plays in someone's life and makes it a lot more helpful to think about what we might need to do in terms of supporting someone if they do indeed decide they'd like to cut down or stop using. And also that environment. What's going on in terms of the connections? Frequently people will describe with methamphetamine that, at least initially, it was much about the connection with others, the confidence to either connect, whether that's sexually, whether that's just socially. We know with some young people, particularly those who are in very unstable situations, you can imagine the attractiveness of a substance that makes you feel quite powerful. If indeed you are in situations where you have very unstable or insecure housing, the ability to stay awake and be alert for long periods of time is actually quite useful in terms of a survival technique. And certainly if we think about some of our people we come across in treatment who are seeking treatment, indeed they may well have experienced trauma experiences, and we know that with trauma comes hypervigilance. And so you can start to also understand why a substance like this that is so powerful in terms of its effect, that it can take someone who's working at quite a high level anyway in that hypervigilance state, pushes them above into something else, pushes them away so that they can at least get some relief, if you like, even though it's bringing them into a more stimulated state. It's the power of that can be very, helpful to people if indeed that they've experienced long experiences of trauma. So I do think that just exploring with clients the role of the substance and thinking about these elements is really helpful. And it does also help us explore that idea of what's going on in terms of polydrug use. It's a very rare thing that someone using crystal methamphetamine is only using crystal methamphetamine, and it may well be because they're using other substances to counteract some of the negative effects in terms of sleep and those sorts of things. I show you this particular video, I won't show you today, but it is part of a ADF campaign around breaking the ice. And I really just wanted to reinforce how useful and important it is to hear from people with lived experience. So to really hear the stories of people who are using methamphetamine. There's some brilliant other sources of videos like this. There's certainly Lives of Substance, which is a great website full of stories from both people who use substances, their families and loved ones, also for different types of drugs, but it really helps provide some insight into the variety of experiences for people who use crystal meth. Certainly there's also your own ICE help that's available to you, and also there's a great series on the VAC website, which is now called, I think, Thorn Harbour, and they did a whole series of videos that are graphically designed with the stories of gay, bi and queer men talking about their experience of crystal methamphetamine. And once again, I think it just brings to life the variety of experiences and helps us understand and to connect with what the things that get in the way of people reaching out for support when they would like it. Which brings me to that idea of really seeing our role as very much around addressing the experience of stigma and discrimination. What we know for sure in terms of the evidence associated with methamphetamine use is that people frequently have waited long periods of time before reaching out for any kind of support. And that tells us something about the compounding of the negative symptoms of use, the increase of concerns around mental health issues. And I suppose it says something to us about the need to break down stigma to assist people to reach out when they need support. Similarly, for families and those supporting someone who uses crystal methamphetamine, it's not the sort of thing that you're going to be talking about around the water cooler at work. And so it is not sort of incumbent on us to really address some of that and say that, lots of people use substances, not everybody. And not everybody experiences harm, but when they do, there is treatment available to them, and that we would encourage them to reach out. So it's always thinking about those elements coming together. So we know, for all substance use, that people may fit anywhere along this continuum, and we want to be reaching all of them. And so messages that are very unhelpful and don't speak to people who use methamphetamine do very little to actually serve the community. And so it's really useful for us to think carefully about how we pitch things and how we talk about substance use in particular, and that we always are thinking in the prevention and harm reduction area as well. We're really talking to people about ways to use safely, to be taking breaks from use where they can, and to really, I suppose, connect with people, because whilst it's what a lot of people who use methamphetamine will tell you is that whilst it may have been used initially to have them feel more confident to connect with others, that over time it actually has them withdrawing from that contact. And so that really tells us something about always exploring with people about the ways in which they support themselves, and they reach out for additional support if they need to. It would also not come as a surprise to you that in terms of the impact of methamphetamine use, we know that there's only so long you can stay up, and so that real experience, which is quite unique to methamphetamine use, in particular, is a very strong binge sort of crash cycle, and it's useful for people to understand that, particularly because we know that for those people who have been awake for many, many hours or days, perhaps not eating, not drinking any fluids, that this experience with very reduced or almost non-existent dopamine levels, they will indeed be feeling very raw and very vulnerable. And I suppose it's very important that we start to talk to people about what they're doing in those times. Certainly, I'm aware of some recent spate of suicide deaths in Sydney, where a lot of that was attributed to this come down phase from substance use. And so I suppose it just reminds us how important it is to talk with people about the need for support at those times. Similarly, it has us thinking too about those who support people using methamphetamine, about the important role they may play in just being present, not necessarily engaging in, big conversations, but that there's some, there's good nutrition available. Those sorts of things about managing the come down is really important, particularly if there are pre-existing mental health issues too, is really about how do we at least ameliorate some of those very low feelings that people will experience. And it's useful for people to understand how that works, why they feel so bad in those crash moments, and that given time and sleep and care, that things will improve too. Because in those moments, it's very common for people to feel like things will never get better, and so suicidal ideation can be very common for people. Which also brings me, I suppose, to some of those other mental health issues, and I think that's also something that's not necessarily unique to methamphetamine use, but certainly sees the great proportion of negative impact for people. We know that for most people who use methamphetamine, they will experience some level of paranoia. Most people who are regular users manage that themselves quite well. They sort of have an awareness of what the paranoia is about, that it's linked to the substance use. And it's not necessarily the case that people will experience psychosis. What we do know, I suppose more anecdotally from people we've worked with or alongside, is that usually someone who's experienced psychosis that perhaps required hospitalisation, even after they've been provided, perhaps they've been placed on antipsychotic medication, provided support, maybe discontinued their methamphetamine use for a period of time, even perhaps got to a point where they're not experiencing active psychosis. If they do use again, it's highly likely they will again experience psychotic or experience a psychotic episode. So I think that's also quite useful for people to understand. It's sort of a bit like a bit of a well-worn path has been created a bit, and so it's useful for people to understand that they really do need support around experiences of psychosis and to understand the best ways they can to manage that, particularly if they're on medication that is acting on serotonin, because you can start to appreciate that obviously with a drug that's working on serotonin receptors and then adding a serotonin drug into the system, it's worth people understanding what the potential implications are about that. It also helps us to understand why people might fall into that experience of what looks on the outside to be, violent. And I suppose it's safe to say that in most, if not all cases, it's coming from a place of fear. And that sort of helps you to understand in that fight or flight space that people are really fearful often for their lives, and therefore has us or signals to us the ways in which it might be helpful to support someone, which is obviously not serving to escalate that experience of fear. And certainly I think we're learning, and certainly through the recent ICE Commission in New South Wales, what came out very strongly is that heavy police involvement in those times of psychosis, bright lights, lots of activity, not necessarily the best approach in terms of trying to de-escalate the experience. Anxiety and panic attacks. Obviously, we know that anxiety is quite common across all. When people experience problematic use of a substance, it's not uncommon for anxiety to be in the mix. But I think it's worth really exploring with people what that looks like, because it also becomes quite confusing for people who regularly use methamphetamine to discern what is a craving for methamphetamine, what is anxiety, what is a craving for methamphetamine, because they all look somewhat similar. And so it's useful for people to be able to reflect on that, to explore that a little bit, because often that can be the trigger for further use. So it's useful to really talk to people about those mental health impacts. And I suppose I put this question up for you really around what procedures or guidelines do you have in your organisation or where you work to support people in distress? Because those are the things that would equally apply if someone was experiencing any sort of paranoia or psychosis or panic attack related to their methamphetamine use. I think we can start to go down the path of being very focused on the challenge, on challenging behaviour, and we need to get prepared for when someone who's using methamphetamine comes into our service. But I think it's safe to say that the best approach in those moments is to just deal with the distress. What we know, particularly with psychosis of any kind, is that the more we fall into the trap of trying to dissuade someone of their beliefs in that psychotic state, the more distressed they will become. So really attending to those experiences or those feelings of distress is far more effective. Really trying to provide a calming, de-escalating approach, and really then, I suppose, seeking that additional support and help. But laying that groundwork very early. So what was very useful where, when working in the stimulant treatment program, was to ensure that we laid that groundwork very early. There may be a moment, there may be a time when we need additional support, so that you're talking to people early about the possibility of additional support around perhaps psychosis, just so that they are aware and it doesn't come as a surprise to them in terms of getting that additional help. I've put a slide in around it, responding to an intoxicated person, but really it's once again, it's dealing with whatever's in front of you. I think we can get hung up a bit about, are they intoxicated, are they not? If they're distressed and they're not well, then, that's when we do absolutely need to call for other help. And I suppose it's really worth noting that in different environments of work, we may not have the capacity to de-escalate the situation and to not wait to really call for that assistance and support, and to encourage, people themselves in the community to be aware of that too. In terms of withdrawal management, we know it's a protracted withdrawal experience. That's helpful for people to understand, particularly given that a lot of our detox programs don't actually work in that way. They're very much oriented around other substances. And so it will be the case frequently that a residential rehabilitation service may receive someone having gone through detox, but who's still very much in that detoxification phase. So really not being in a position to engage in groups or counselling at that moment. So that's helpful for workers to understand that it is a prolonged experience. There's a long, particularly for protracted use of methamphetamine, there is a long sense of flatness, of disengagement, lack of motivation, those sorts of experiences. And so that can often be misinterpreted as disinterest and not wanting to engage in treatment. So that's really helpful for people to understand that it might not be that, and that frequently people will have very vivid dreams about using, that they feel like when they wake up they've been using. So there's lots of difficulties around the withdrawal symptoms, and I suppose too there's also that experience of kindling, which is really about people who've tried multiple times to withdraw from a substance such as methamphetamine, and it becoming increasingly harder to do so in terms of managing some of the effects. So it's worth speaking about that. In terms of pharmacotherapy, we're really we're discovering more and more as we go, but it is absolutely true that we haven't really landed anywhere in terms of a useful evidence-based pharmacotherapy. Certainly when I was working in Sydney in the stimulant treatment program, we used amphetamine, and it's a short-acting stimulant, didn't really hold people for very long. However, in combination with counselling, for those who are really at that pointy end of homelessness, HIV, being HIV positive, general health being very poor, it was a really good way to keep people connected. And I suppose what we would always say about pharmacotherapies is that they should be used in conjunction with other supports. That's like, it's as part of a package of treatment. But the NCRED have recently done a review, and they looked specifically at a whole range of different pharmacotherapies being used, and also what's on the table now in terms of trials coming up. We know that Rebecca McKetton's crew have been looking particularly at, I suppose, a different approach to pharmacotherapy. The Liz-Dex trials are now currently happening, and Liz-Dex being a longer-acting pharmaceutical stimulant. And I suppose, once again, really wanting to place that in terms of some of the other supports that are necessary. Methamphetamine has been looked at, and there are other registered trials that are going on. I think it's safe to say, though, there's not really been any conclusions about their effectiveness. But once again, I think with substance use treatment, it's really about, there's no one size fits all. It's thinking really broadly about what might be fit for the person who's in front of you. And certainly when there are other complicated factors going on, where other treatments have not been effective, or that person's starting to feel like there are no options for them, I think it's worth exploring other options, thinking about what trials are going on and whether they might be a good candidate for exploring a pharmacotherapy. It can certainly help, if nothing else, with reducing some harmful use and certainly keeping in contact with a treatment service, and that can be the real benefit of some of those. In terms of other treatment interventions, I think it's worth mentioning that there's a few things going on. Certainly in New South Wales, the SCheck clinics were designed to capture people early on, and that is to say people who perhaps weren't concerned about their methamphetamine use at this point, but it was helped them to get a physical checkup to see if there had been any impacts. We know for some of the, so for some people who use methamphetamine who are in the older age group bracket, there is a propensity or there are risks for things like stroke, for example. And so, it's good for people to get checked out. They were being assessed by counsellors as well in a very brief sort of package of sort of 4 sessions where information was being provided to them, some brief intervention, motivational interviewing was being provided. And I suppose it just tells us that we do need to think quite creatively about how we capture people early, so that if there are issues that we can feed them into ongoing support. The SCheck model has been designed into an app that's due out, I think, end of December, hopefully, and that will obviously allow very much that self-use, so self-monitoring of where people are at in terms of their physical health, their sleep, and some tips and tricks, I suppose, for managing use and perhaps even taking a break from use. Obviously, some web-based things have been used too, specifically targeting Aboriginal and Torres Strait Islander clients. There's a good study by James Ward around that. So I think, once again, these using technologies can be really helpful. And we know that other types of treatments that are used to treat anxiety, such as computer-assisted attention bias modification, which really, I suppose, has been raised out of the anxiety space around helping people to not attend to traumatic or stressful events and to shift their attention around that, and that's in terms of computer. In terms of the repetitive transcranial magnetic stimulation, once again, not necessarily conclusive, but it's looking at approaches that have been used for people perhaps who've had depression, quite intransigent depression. Other things have not worked. Medications have been used and not worked, and so they're looking at stimulating outside of the brain, so it's not intrusive in that way, and really. But in terms of conclusions, I think it's the jury's still out on a lot of these. As I'm wrapping up, hang in with me. We're almost there, so keep your questions coming through. What's really important is that focus on welcoming and attracting variety of clients, thinking about the environment in which treatment or support is provided, being really flexible, knowing that if sleep patterns are being disrupted, that binge crash cycle is happening, the reality of people popping in for a 9 a.m. appointment might not occur. So being flexible about how services are delivered, really linking in with mental health and other support services if possible, and I suppose too, sharing with people and exploring the very physical nature of methamphetamine is hugely helpful. So really even just practicing some of those, bringing down that heart rate, breathing rate in the moments they're with you, so that there is some ebb and flow of that hypervigilance can be really effective and helpful. We know that a good assessment is important, and that any of the best practice approaches, which I'll flick through, which will be of no surprise to you, it's the relationship. It's absolutely geared around how you build that rapport with someone, that you're really tapping into understanding the role of the drug in their lives, that you're absolutely taking a client-centred and strengths-based approach, that you're thinking about, if methamphetamine is the one tool they're using to deal with their distress, how can we add other things to that mix, rather than discounting the way in which that person is using methamphetamine to manage their lives, and absolutely thinking about people's general health and well-being. Growing those things that perhaps have fallen away as a result of their substance use is really critical and really helpful. We know that stepped care is useful, so that is to ramp up the care or think about other options if things are not working, which really tells us something about the importance of checking in with clients. Is this working for you? Are you getting something out of this interaction? And if not, what can I be doing differently to shift things around, explore other options with you? Absolutely, we know that counselling, resi rehab and support groups can be helpful, but we're also really wanting to tailor it. You know, it's not a one-size-fits-all, and mindfulness is important, of course, because that deals with some of that high levels of heart rate, of breathing rate, etc. We know that counselling does absolutely work, although the jury once again is out on specifically around, you know, which is best. Is it CBT? Is it, you know, acceptance and commitment theory? I think the main thing once again is the relationship, checking in with the client, ensuring that they're getting what they need or want, and certainly I suppose being mindful of the fact that if things are very cognitively based, i.e. on memory, on planning, on problem solving, remember back to those earlier slides about the impact on that higher functioning. You know, when they're in that fight or flight mode, and that may persist with low levels of dopamine and serotonin that regulate things, possibly that executive functioning to plan and, you know, cost benefits analysis might not be working so well when they're with you, depending on where they're at in terms of their use. So, you know, it's useful to really tailor things to where that person's at and get a good sense of how they're travelling in terms of what they can take on board and recall. Absolutely, we need to be talking about sex with people. We know that a range of, you know, alcohol and drug use is associated with sex. It helps with our confidence. It can get us into difficult situations. And so I think it's useful, though, to talk about the fact that for some men who have sex with men, it plays a significant role in their sexual adventure. It's worth talking with them about that, and also reassuring them that there is sex life after meth. So a lot of the work that I do now is specifically around reigniting and re-establishing sexual intimacy when people have decided that they need to discontinue methamphetamine use. And so it's reassuring people that that is possible, and really trying to understand or support people where they're at in terms of the role methamphetamine plays in terms of sexual adventure and sexual experience. We absolutely need to be working better in partnership with mental health. And for those of you who are doing that, I applaud you. It's great. You know, coordinated, collaborative care. It's sharing your knowledge of how substances work. It's really, I suppose, working in partnership so that people that we are here to work with get what they need. It is the case that people who are experiencing mental health issues as a result of their methamphetamine use absolutely need assistance, and it's unlikely, perhaps in the short term, that they may stop that use. And so they need help, you know, while they're using, and you know, if that's what they choose. And so we really need to try to bring the mental health system along with us to support people in those moments. And there's some great examples of good collaborative work, and we need to grow those. We absolutely also need to think about working with families and significant others. You know, they're the mainstay of the supports out there in the community. Whatever treatment that's provided is usually pretty brief. And so providing them with as much information and support as we can, alerting them if they're living with someone about those binge and crash cycles, about how best to respond is useful, what psychosis is, what it looks like, and having some crisis plans if indeed that's necessary. Family drug support is a good place to start. I'm sure that there are lots of other support services here in Queensland that are associated with treatment services. It's worth bringing them on board. And I think really it's once again saying, getting the message out, there is treatment available, it is effective, and there's ways in which we can fit families and support people into getting some help for their own needs as well. We need to really encourage them to get their own self-care happening. And so as a quick and dirty tip, it's really about in terms when we're talking about families and significant others, it's validating their distress, their experience, giving a little bit of airspace to that experience, providing education where we can, and then facilitating that ongoing support as well. Really take that ecological view with this. Try to really think beyond the bounds of that individual that's coming to see you, and you're tailoring your work around them. But think beyond that. Are you talking about where are their support networks? Do you have the opportunity to link them in with other people, other supports? And I suppose too, thinking about what works with young people. We often forget that when it comes to adults. We sort of strip that all away and think that the one-on-one's going to be the answer. And I think we know that it's a bigger picture than that. Absolutely, our important role is in terms of community education, providing those community supports, and absolutely fostering those mental health pathways where we can. It is incumbent on us to get the information out there to people that there are support services available. They can ring places like Addis, they can ring places like Family Drug Support. There's also ICE Help here in Queensland, really helping people to get the right, correct information, to know that there is hope, there is things that work, and that they're not alone in this journey, which I think we really need to support, is just really ensuring that people know that this is not an isolated situation, that some people do experience issues and there is help available. And that's it. So I've banged on way too much, but what I hope is that you really have taken away that idea that we're really thinking broadly beyond one size fits all, that we're thinking about that community approach, bringing families and support people on the journey where we can, that real broad expression of what is family. And I suppose too, thinking about all those aspects of someone's life. What role is the substance use playing, in their lives? So I will now take any questions that you have and I will answer them to the best of my ability. And if I can't, I'll certainly point you in the right direction of some good information.
Thank you, Suzie, for a really good presentation.
You're welcome.
Do have a couple of questions.
Brilliant.
First one is, what was the treatment you mentioned for anxiety?
So there's a couple of treatment ideas that have been taken from anxiety, and one of them was one's around stimulation. So it's basically stimulating the part of the brain that is sort of responsible for anxiety. Now, I'm not an expert in that area, but if you do look up extracranial stimulation, you'll find some studies on it. I suppose what I've managed to find out is really that, like other treatments for anxiety and depression, it's based a lot on trying to stimulate those areas of the brain responsible for managing anxiety. And so it's really implemented almost towards the end of it as a bit of a last resort. So where other medications and therapy have not hit the mark, it sort of moved into those areas. Similarly, in terms of that, those other computer-based skills, they've been used a lot in anxiety treatments, and I think they're trying to take the learnings from those, like things like cue exposure, those sorts of things, and try to apply them in this context. So I think once again it's worth really checking out the evidence for some of these practices, and I raise them here just to say that there's lots of different ways of things going on, and it's incumbent on us as people in the area to keep our eyes open to what's happening out there. But in every case, I think it's really important to look at the evidence base and ensure that people are actually getting holistic care, so not just one thing but that other additional support.
And another question. It is common for our clients to mix methamphetamine use and antipsychotic medications such as Serotonin.
Yes.
Can you serve specific risks or research around this?
Yes. So there are a couple of things specifically around serotonin toxicity, and it is worth looking into some of those. I know that QNADA, and maybe in conjunction with Insight, put out some resources around the interaction between pharmaceutical prescribed medications and illicit drugs, which is worth checking out. But I think it's safe to say that it's a very individual thing, and it would be worth talking to clients about the general picture. So, how does this antipsychotic drug work on the brain? How does it work? And then how does methamphetamine work, so that they are educated? Because it's very hard to be categorical about the effect for that individual person. But it is safe to say that people can have experienced serotonin toxicity, and that can have an impact not only mentally but also physical expression, which is obviously distressing for the person and can be damaging to the brain. So it's worth exploring that with the person, also getting some counsel or consulting with mental health professionals, just so you feel a bit more confident about that. But it's important to say to clients that for that individual, we don't really know what might happen, because some people will say also that it's useful for them to not stop taking those antipsychotics because they could have a protective effect. So worth I suppose being speaking broadly, but I suppose not being able to give specific advice to people, given that everyone is very different.
Well, that's all as far as questions go.
Thanks.
Yes, so I'd like to thank Suzie again for a great presentation, and what a bonus it was to have on Happy Friday.
Yeah, well, thank you very much for having me. There's lots of great resources out there. I'd really implore you to check them out. There's lots of links on the NCRED website. If there's any questions that you ever had for me or you'd like to get in touch, please do, and Inside will be able to provide those details to you. Have a great Friday, everyone.